So my name is Mary Jo Strobel. I'm APFED's Executive Director, and it is my honor and pleasure to be the first to welcome you to EOS Connection 2024. This is APFED's 22nd Annual Patient Education Conference for Eosinophil-associated diseases. I have a few housekeeping notes before we get underway. The restrooms, if you haven't found them yet, are in the hallway right behind us, across from the Wisconsin room. Feel free to take breaks as you need them. Teens, if you have a teen here or a child here today, they have a choice of attending the sessions, but you can find them up on the third floor with the youth organizers in the Auburn room. For those needing on-site access to food storage, a refrigerator, a microwave, and paper products, a hospitality suite is located on the 14th floor, room 1418. If you are using Wi-Fi, the network is Hilton Honors Meeting. The password is TBH Leo Standard. I would also invite you to take a moment to download the EOS Connection 2024 mobile app from the Apple app or Google Play stores. You'll need the email address that you use to register for this event to gain access, but we will have a few live polls for you to participate in this morning, and those responses are going to be submitted through that app. So please take a minute to download it if you haven't already done so. I also wanted to take a moment to thank our collaborating partners for their contributions in shaping today's program, as well as the many education partners who supported our conference this year and made it so accessible to our community. Many of these teams are on site today and tomorrow and have resources and information at their exhibit tables, which are in the ballroom next door. So to get started, I wanted to take a few minutes to briefly walk you through some of the highlights of the exciting things that have taken place since we held our conference last July in Denver. Our community has accomplished so much more. You can learn about all of the achievements by visiting apfed.org and go under the About Us tab to find that. But first, since last July, we have awarded 2 HOPE grants thanks to the generosity of our donors and volunteer fundraisers. Both researchers will receive $100,000 over a 2-year period. Dr. Sagar Bapat from the University of California, San Francisco, will be studying how our diets affect our immune system. And Dr. Narit Azus from Cincinnati Children's Hospital will be researching the lining of the esophagus and how it's affected in EOE and studying a pathway that may be able to restore barrier dysfunction. We also provided the Consortium of Eosinophilic Gastrointestinal Disease Researchers, or SIGR for short, with $70,000 in grants since last July, which include $20,000 to support research looking into the demographics of esophageal food impactions in national emergency departments. And most recently, in May, we awarded SIGR $20,000 in support of a study to learn if people with eosinophilic gastritis experience problems with stomach emptying, and $30,000 to support the development of a research scholar through an APFED-named scholarship. We also co-funded a grant with the American Academy of Allergy, Asthma, and Immunology, and each of our organizations contributing $70,000 to support a total of $140,000 to Dr. Maureen Bauer of Children's Hospital Colorado, who is studying how well the esophageal string test can detect EOE in children who have other allergic conditions to gather preliminary data necessary about the impact of screening for EOE. So we look forward to sharing the results of this research with you for those projects when they become available. In May, we celebrated the 3rd annual World Eosinophilic Diseases Day on May 18th, and here in the United States, we celebrated National Eosinophil Awareness Week during the 3rd week of May. So on the screen, I've included a collage of a few pictures. Some are my own personal photos of people that I saw during the week celebrating, and other pictures I found on social media with the hashtag NEAW and EOSAware. More than 60 landmarks around the U.S. participated in our Light Up for EOS campaign this year, lighting up magenta to raise awareness of eosinophilic diseases. And I wanted to share just a few of those images. City halls, government buildings, airports, sports stadiums, and landmarks like the Niagara Falls participated this year. And probably one of my favorite pictures showing community member Alex, whose mother Beth made great strides to have lightings hosted in Lexington, Kentucky. So thank you, Beth and Alex, for sharing such a great photo. And during this special week, we also launched a public awareness campaign on the digital display of the NASDAQ Tower in New York City. And this ad taught visitors to Times Square about the common symptoms of eosinophilic esophagitis and prompted them to speak to a doctor if they recognized those symptoms. So the ad was not only visible from the streets of Times Square, but it could be seen by many who were watching the footage from a live webcam in the square. So as you can imagine, we were really thrilled to have been invited to utilize such an attention-grabbing platform to educate and raise awareness. The billboard stands 10,000 square feet, 7 stories tall, and it has over 18 million LEDs, so it was really a spectacular opportunity. I'm also beyond thrilled to share that in May, we began film and production work to produce an EOE public service announcement for television. The aim is to teach the general public about EOE and showcase the impact of dedicated support. Through an invitational partnership, APFED's TV segment will be part of the Viewpoint with Dennis Quaid series. And we'll have a series of digital assets available for broad dissemination. A public TV segment will be made available to 370 public TV stations across the United States to air during free airspace, reaching an estimated 5 to 8 million viewers. We'll also have a 60-second segment distributed to cable networks such as CNN and Bravo. And we'll have a 6 to 7 short documentary made available online. We are in the final stages of production, and we expect to have the project wrap within the next few weeks. So while this particular piece is focused on EOE, it really does help raise broader awareness of eosinophilic conditions, and it's a fantastic opportunity to reach very large audience. So stay tuned. No pun intended. Navigating a new diagnosis can be overwhelming, and nobody should have to do that alone. So to that end, we're thrilled to announce the availability of a brand new comprehensive digital toolkit designed to help those with EGPA, particularly those who are navigating a new diagnosis. We developed this resource in collaboration with the Vasculitis Foundation, and this is the very first announcement we're making of its availability. I think we wrapped this up the day before yesterday, so we're really excited to have that. The resource contains a wealth of information, a glossary, FAQs, treatment information, and tips for better living with EGPA. So you can download this from our website, apfed.org. You can access it through that QR code, but you can also visit AstraZeneca's virtual booth in our conference environment, where there is a link to our site for download. So we're really, again, excited to have that resource available, and both APFED and the Vasculitis Foundation will be distributing copies to clinicians so that they can share it with their patients in clinic. Since we met in Denver last July, we also advocated for patients in meetings with decision makers in managed care, insurance companies. We've supported federal bills to enhance access to care, treatment, and improved ingredient labeling. And we've shared patient voices and needs with clinicians, scientists, policymakers, and government agencies. So again, these are just a few highlights of the progress that we've made over the past 12 months with your support and because of your involvement. So we all have much to be proud of. Patient input is critical for advancements, and it guides science, education, and advocacy for better care. And so to that end, I wanted to highlight an example of a recent publication that was launched last May and touch on a few key highlights of the Life with EOE report. So why is capturing patient experience so important? First, personalized care. Each patient's journey with eosinophilic disorders is unique. By tailoring treatments and support to individual needs, we can ensure that care is not just effective, but it's also relevant to personal experiences. Second, it provides insight into challenges. Understanding the struggles faced by patients is crucial. These insights help us to better address the needs of patients, whether it's managing symptoms, accessing treatments, or coping with the emotional impact of a diagnosis. Third, continuous improvement in healthcare practices is essential. Integrating the latest research, best practices, and patient feedback can enhance that quality of care and patient outcomes. By engaging with policymakers, we can improve that access to care and address other systemic issues that affect our well-being. And lastly, education empowers everyone. It fosters a better understanding of eosinophilic disorders and effective management strategies. So together, these 5 areas give us a comprehensive approach to supporting patients and families. And the patient voice is the foundation of each of these areas. Last July at our conference, I had shared with you a report that had been newly published at the time. The Asthma and Allergy Foundation of America and APFED worked together to conduct a multi-component needs assessment study for EOE. The study aimed to understand the patient journey, as well as the healthcare providers' awareness of and practice around EOE in the United States. And these results were published in the Life with EOE report, which is a really comprehensive document that walks readers through the study results, and it highlights the experiences, challenges, and needs that were outlined by EOE patients. Participants included adults diagnosed with EOE, caregivers of those with EOE, and healthcare providers who treat people with EOE. We had a fairly equal number of both patients and caregivers who participated. More women participated than men. The majority of the respondents were between ages 40 and 59. 29% were older than 60, and 21% were aged 18 through 39. Caregivers reported the person's age to be up to age 11 for 45% of them. 41% of the participants were aged 12 to 17, and 14% 18 and older. About half were in suburban locales, and urban and rural equally comprised the remaining respondents. We sought multiple types of providers to get a range of experience from different clinicians who treat EOE. About a third were GI doctors, about a quarter were primary care physicians, and about a fifth were allergists or immunologists. The remaining participants were ENTs, nurse practitioners, physician assistants, ER doctors, and other types of clinicians. The majority have been practicing medicine for over a decade. 4 in 5 work in private practice, and nearly all practiced in suburban and urban areas. So the graph at the top shows the patient's age at the time the diagnosis was made, and more than a third of patients and caregivers in this study reported receiving an EOE diagnosis before the age of 12, with an additional 27% receiving the diagnosis between ages 40 and 59. We captured insights into the timeline between symptom onset and receiving a diagnosis. So the purple bars in the second graphic show that the responses from healthcare providers, and you'll see that more than 3/4 of clinicians indicated that patients receive an EOE diagnosis within the first 6 months of seeing them. And their answers, the clinician answers, varied greatly from patients and caregivers who said that from the first time they noticed symptoms, it took a year or more for them to receive an EOE diagnosis, including 14% who said it took more than 10 years to get diagnosed. So these results indicate, the importance of seeing the right doctor for a timely and accurate diagnosis, and the importance of connecting patients to doctors who are knowledgeable about EOE so we can reduce that wait time. Patients and caregivers who reported that it took 1 year or longer to get diagnosed with EOE, 29% of them were originally misdiagnosed, 27% had trouble finding a specialist, and 23% had trouble getting the necessary testing. So these numbers were significantly lower in the patients and caregivers who reported that it took 3 months or less to get diagnosed. Among those who indicated that they had challenges seeing a specialist, 2 in 5 said it was because the wait time to get an appointment was too long. 1 in 5 indicated that they didn't live near a specialist. And we included an area on the survey so that people could provide additional insights about challenges that weren't in the answer choices. And some had mentioned a general lack of awareness around EOE, in that they couldn't be referred to a specialist if their doctor didn't know what to look for. And in some cases, the patients reported that the doctor was dismissive of their symptoms. From the healthcare provider point of view, nearly half indicated that they don't refer patients out to GI specialists when the treatment plan that they have provided is helping symptoms. 2 in 5 also cited vague or transient symptoms as a reason for not referring to a GI specialist. And they were less likely to cite access challenges as a barrier to referral, such as the specialist was not accepting new patients or not being able to find a local specialist. In this study, patients and caregivers and clinicians agreed that the most challenging symptom of EOE is difficulty swallowing, followed both by food impaction and reflux. Both groups agreed on challenging aspects of symptoms like stomach pain, vomiting, decreased appetite, and stunted growth or poor weight gain. While many patients with EOE find relief after diagnosis, having a name for their condition and working through a treatment plan unexpected challenges still can arise. More than half, 64% of the patients and caregivers said that diet management was one of their biggest challenges in managing EOE. 2 in 5 also cited the effectiveness of care and treatment as one of their biggest challenges. In our study, patients and caregivers said that EOE has the biggest impacts on physical health, emotional health, and social life. And their insights differed from the clinicians' insights. So in general, the doctors perceived that EOE has a bigger impact on the patients than what the patients had self-reported. And why is that? It may be that patients consider EOE as just one factor that impacts their life, whereas the clinicians are seeing the patients within the context of EOE management and the challenges that might come along with that. So the Life with EOE report highlights several critical issues faced by patients. First, diagnostic delays are common because the symptoms of EOE often mimics those of other diseases, making timely and accurate diagnosis challenging. Additionally, multidisciplinary care teams are frequently needed to manage the different aspects of EOE. The report also underscores the frustration and the challenges that are stemming from the limited number of FDA-approved treatment options. But it's important to note, however, that at the time of the survey, the only FDA-approved treatment for EOE was a biologic that had been approved for about a month. A primary challenge in managing EOE is adherence to treatment plans, especially dietary therapy, which can be particularly demanding. So how does this report help? It contributes to the knowledge base by providing a very comprehensive data on patient experiences, which is invaluable for understanding the condition better. It raises awareness, it educates the public, the healthcare providers, and policymakers about the challenges faced by those with the condition. And it supports the need for research and programs by highlighting gaps in knowledge and care and really underscoring the necessity for continued research and targeted initiatives. But it also supports personal advocacy. Empowering patients with information can help them, in turn, advocate for better care and resources on their own behalf. So I'd like to extend my thanks to our collaborators at APFED and all of the survey respondents, many of whom are online watching or in the room today. I really encourage all of you to consider participating in surveys that APFED shares because your responses really do help advance the field. If you would like to, see the report in its entirety, you can do so from that QR code and on apfed.org/EOE Life. So I'm hoping our tech problems may have smoothed over, that we are able to do a poll. Okay, I'm giving a thumbs up that we can. So I thought it would be great to capture your experiences with a few poll questions. And this would be for those of you in the room with us, if you're watching us live virtually. All patients, caregivers, family members of a person affected by any subset of eosinophil disease, we would love to hear from you. So I would ask that you open your EOS Connection 2024 app, which can, again, be found in your app store. Log in with your email address. On the home screen, you'll see a square labeled polls. And if you tap that, you can access our first poll. EOS Connection 2024. You can recognize it by the APFED logo. It will be in the Apple and Google app stores. So the first poll question asks, which statements do you agree with? Please check all that apply among the choices. Please check one choice. Let's go with which statement do you most agree with then? Do you feel it took too long to get the correct diagnosis? Were you originally misdiagnosed? Did you find it hard to find a specialist or get an appointment with a specialist? Did you have challenges accessing testing? Did you have challenges accessing treatments? Or was it none of the above? So it looks like so far the majority are experiencing challenges in accessing treatments, followed by it took too long to get the correct diagnosis. Behind that, a close third is they found it hard to find or get an appointment with a specialist. And for some, it was something else altogether. So we have one more poll question. Again, this would be for all patients, caregivers, family members with any subset of eosinophil disease. We want to know about the impacts of the condition. So assuming that you cannot check all that apply, let's go with the most that you agree with. What impacts do you or your loved one experience? Is it emotional health, impacts to emotional health, social life, travel, D, finances, E, school or work? Is it family planning, relationships? Is it something else? Or is it no impacts at all? All of the above is a choice too. And that looks like the vast majority of you are indicating all of the above. So that impacts everything. Second to that, emotional health. School or work is also a big impact. So thank you. I can't move on from the poll slide, but now I can. So I want to close just by emphasizing the importance of your voice in healthcare. It can improve outcomes, it can inform tailored and effective treatments, and it really drives informed decision making. So thank you for your time. And I'd like to hand the mic over now to Ryan Piansky, who is a community advocate who's going to moderate a patient voices panel. Ryan is a college student at the Georgia Institute of Technology. He has eosinophilic... Yeah, no, you're fine, you're fine. I thought you were going to correct me and say you don't go to school anymore. So, he has EOE as well as eosinophilic asthma and follows a restricted diet. He understands all of these challenges, lives them firsthand. So despite the health challenges, he does lead a very active life, including traveling, living abroad, and supporting patient advocacy, education, and research initiatives. So thank you, Ryan. You ready?
Thank you. Yeah. Sorry, I jumped the gun. I stood up too early. I am very excited to be here again. I've been around with APFED for 20 plus years at this point, and the annual patient conference that we do is one of my favorite events. It's so wonderful to see everyone that I've grown up with and that have watched me grow up over the years, and also to see some new faces. You have all heard me talk so much over the years, and Mary Jo just did a lovely introduction. So I am very excited to introduce our panelists for the day. If our panelists can go ahead and join us, that would be wonderful. We do have Don McCoy, who is a caregiver for her 13-year-old son who was diagnosed when he was just 2 years old. We have Deb. Is Deb here? Yeah, perfect. That's Deb right there. Deb is a patient with EOE, and she's been living with that for 16 years. Heidi. Do we have Heidi here with us? There we go. Heidi, hi. Heidi is the caregiver for a teen daughter living with EOE, who has dealt with feeding tubes all the way up to biologics most recently. And then virtually online, I think we have Jenny Wong. There's Jenny. Hi. Jenny is an allergist and immunologist, as well as a patient advocate living with eosinophilic gastritis. So I am absolutely thrilled to have all of you here with me today. And no one can explain your journeys with your diagnosis better than yourselves. So if we can go ahead, Deb, would you mind starting us off, telling us a little bit about your journey with EOE?
So I have EOE and just recently diagnosed with eosinophilic asthma. So my EOE pathway was at least 16 years, and it seems like forever. It took me, gosh, I don't even know how long to get a diagnosis. I was in the ER, and I woke up after they pushed food through, and the doctor said, "I know what you have." So thank goodness. And, you know, I still struggle today, but I'm one of the luckier ones. I don't have, you know, typically any swallowing issues. It raises its ugly head every once in a while, but, you know, I'm very lucky with that. With the asthma, I think, you know, after having a bout of COVID, it kind of kicked in with the eosinophilic asthma, but at least I know what it is now, and I'm looking to get some help with it. But, you know, again, I'm one of the lucky ones at this point, but the journey was just so long and very difficult. So, you know, I have a lot of food restrictions, but I watch it daily, and I get through it. So I'm managing it instead of them managing me.
That's really wonderful. Yeah, the diagnostic journey I know is so difficult for so many people. So we're really glad you were able to get that diagnosed finally. Dawn, could you tell us a little bit about your journey with your son and EOE?
Yes, thank you, Ryan. My son started to manifest under a year old, just that he could not keep food down, showed symptoms of asthma and eczema, sort of a complication therein. We didn't get diagnosed till he was about 2 years old. We were looking for pediatricians and providers who could give us answers about what he needed or what was the problem. His hair was falling out, and they said, don't try Selsun Blue or some other things. His skin was scaly, and the asthma and eczema were kind of pivoting, so we were in and out of emergency. It wasn't until we got a more formal diagnosis after an endoscopy that it was EOE. And in fact, not knowing how to manage that, they just said, stop all food, stop nursing, stop everything. So it was kind of a cold turkey situation that we went into treatment. Had to wait about a year to get on a feeding program. There was a wait list, as well as to get it to a dermatologist. So we made him as comfortable as possible, and our journey continued where he showed developmental delay signs of autism. Knowing that he couldn't speak until he was about 5 or so. Weren't really sure again what was manifesting. The EOE diagnosed, but now there were other conditions. Thankfully, we had a really good team in Virginia where we live who were able to help put it under control. We went to some of the top doctors in the nation. Thankfully found APFED early on in his journey to help get him diagnosed. He's here today. He's now 13. And the journey had been, we did not put him in school initially because the challenge was that he was reacting to sensory and sounds and from the autism, and then reacting from the food and other ingestion, not just ingesting foods, but smelling them. Thankfully, he did get some treatment. We got him stabilized with some elemental formulas, and in more recent years had a G-tube inserted to help keep him out of the hospital with failure to thrive. He is mainstreamed in a middle school now, and very much managing his care. It's been a journey, and certainly would love to share about how we found the right people, mostly through APFED, of course, it being a resource for us. but also his journey now socially as he enters into young adulthood. As a young person at 13 who thinks he's 21, and I'm like, wait, learn from Ryan and others, you know. So I'm glad he's here. I'm glad that we're here to share a story about his journey to managing EOE.
Yeah, I'm excited to say hi to him later. I haven't gotten to see him yet this conference, but I remember when I was a little kid and he was an even littler kid, like us running around the conferences together, so it'll be nice to see him. Jenny is joining us virtually. Jenny, would you mind sharing a little bit about your experience with eosinophilic gastritis?
Yeah, I was diagnosed about 3 years ago. Sorry, I'm hearing an echo, so it's kind of disconcerting. I was diagnosed about 3 years ago. I was a resident, an internal medicine resident at the time. I started having a lot of abdominal symptoms and vomiting and interesting experience with both nutrition and obesity. So I was in denial, but I had great doctors that took care of me. For eosinophilic gastritis, there's no like FDA approved treatment. So initially I was on a pretty restrictive elimination diet before I figured out what my specific food trigger is on. And to this day, I'm still on dietary restriction, but thankfully I'm doing a lot better.
Yeah, that's wonderful. We did a podcast episode with Dr. Jenny Wong to discuss this because your diagnostic journey was just so interesting, being in this medical setting and seeing patients with eosinophilic disorders and kind of recognizing those symptoms in yourself. So I'm very glad that you're here as well. Heidi, another caregiver on the panel, would you mind telling us a little bit about your journey with your daughter's EOE?
Sure, thanks. So my daughter Carly is 14 now. She was a preemie, so she 33 weeks when she was born, and started out with a lot of reflux issues and then eczema and then food allergies. She was diagnosed at 14 months old, and then she was on the Neocate splash, but she didn't like it. So she wouldn't really drink enough to thrive, and she wouldn't eat enough. So we had a feeding tube journey. It took us several years. She was 7 when she finally got her feeding tube placed. So that was a struggle. And then she started to thrive after that. She's at the point now, we put her on Dupixent about 2 years ago, and she's doing much better. So we don't need the feeding tube now. She hasn't had that used in over a year. She also has cecostomy for chronic constipation, but she's afraid to have it taken out because it's such a part of her, and it helped her so much when she was so sick. So that's our new struggle, is trying to convince her that she doesn't need the feeding tube anymore. But the Dupixent's been life-changing for her. The feeding tube truly saved her. And then she was just diagnosed with an intellectual disability and autism this year. So that's another new thing that we're dealing with.
Yeah, it's very interesting to hear about the feeding tube. I personally had a feeding tube myself and kept it in for, I think, 2 years after I last used it before I was ready to take it out. So that's it's wonderful that she's on the biologic now and that's been helping so much. On that note, I think it would be really interesting to hear about everyone's different treatment options. I know, Jenny, you mentioned some food restrictions. Everyone up here has also mentioned those as well. But if you guys could give a little bit of insight as to the different treatment options that you guys have tried over the years. Heidi, if we could start with you, was there anything between the feeding tube and the biologics that you guys were using to manage the EOE?
Sure, we had to do the stop everything in the beginning as well, stop breastfeeding, went to the completely elemental, and then slowly had added foods back. Sweet potatoes was the first. So she was just on that for a while. And then we did the swallowed viscous budesonide for quite a few years. She didn't like it. We would mix it with applesauce or with the Splenda, but she really, really didn't like it. And we would have mixed results with the scopes. It helped. But then finally the Dupixent made the hugest difference. One of the big things with her is eczema. She had eczema on all of her creases, her fingers and under her ears, and she would bleed. It was so bad. She couldn't sleep. She was scratching all night long. So the Dupixent was huge for helping with that, and we were able to get it approved through her dermatologist first because it hadn't been on-label use for EOE yet, and we're still technically managed under the dermatologist for that. But it really made a big difference. And then the Neocate splash was all she could drink for a while. And then the feeding tube to finally get her enough, because she's supposed to drink 3 to 4 boxes a day, and we'd usually only get 1 box in before the feeding tube. So she was only 36 pounds at 7 when we got the feeding tube. Her feet hadn't grown for years, so she really needed that feeding tube.
No, absolutely. That's yeah. The Neocate is and all the other elemental formulas are something that could be so helpful. But I remember for years so many patients refused to drink them, and then the feeding tube is a great way to help with that. Deb, could you share a little bit about your treatment options over the years?
Yeah, so I'm mostly on Zyrtec and Singulair, and it seems to help me just, manage everything. But I have tried in the past the swallowing steroid, but I get thrush easily, so that has been really problematic when I've had flares, because, taking the steroids, within 3 days I have thrush. And, I not only have just a small bout of it, but I have a bad one. I have not tried Dupixent, so I'm interested in learning more about that here. I don't think that I need it at this point for EOE and the asthma, but who knows? These diseases just, no matter what happens every day, I'm just like, wow, what was that? One of the things that I struggle with is in the mornings I can tend to have a low-grade fever and nobody can figure it out why. But then once I get going, I'm good. Now it's not every day, but it's when the flares are. So, right now I'm doing well, so.
Fingers crossed, that we keep it that way. Good, yeah. And Jenny, you're our only panelist up here with eosinophilic gastritis, and as you mentioned, there are no approved treatments for that yet. So you said you're mostly managing your EG with a elimination diet.
Yeah, so I am on strict milk restrictions. I don't eat any type of milk product. Initially, when I was first diagnosed, I was on a 6-food elimination diet, and that was my choice. My doctors had offered me anywhere between 2, 4, 6 food, and I was like, I'm going to try the 6. And so I was on 6 briefly, and then 5, 4, 3, 2, 1, and eventually it just became milk.
That's good that you're able to identify the real trigger that was causing so many issues, and I know milk is such a common one for so many in the community, so I'm glad you're able to narrow it down to just that, because the 6-food elimination diet it's hard. It's a hard one to manage. Yeah.
It's extremely difficult. It was really hard, and I'm glad I'm not there anymore.
Definitely. And then Dawn, treatment options for your son over the years?
Yep, I'm going to echo what some of the other panelists have shared about the elemental was sort of our first stop. And I'll just say not all elemental formulas are equal. Josh would try the grape, and that would not work for him. And then we tried orange. Finally, it was a combination thereof. There's a level of corn in one or the other that offended his system. So we just didn't go with that. We said, let's blend this. We did the budesonide. I'll just say he learned to walk with steroids in his system. So here he was flying across the room, and I was like, great, doing the swallowed slurry was just a journey. Mm-hmm. The feeding tube I mentioned, as well as most recently, even though he does have a restricted diet, the Dupixent we just started in December, it's been absolutely life-changing. Now our hurdle is he has sensory issues and autism. And so the challenge of eating a hamburger with all those textures together and the concepts of trying to process different foods combined, that's a hurdle. So even though now we've got, great, we can eat, we can have the dietary intake, now we have that other hurdle. So it's just a journey.
Yeah, the food textures is a hurdle that I personally was not prepared for when I was able to start eating food. So I'm glad you're at that point in the journey, and there's always more journey to have together. So we'll see how that goes, but hopefully it'll go well. I'll just for a minute, if there are any audience questions, please raise your hand. I think Cara has a microphone that we can pass around. but while people are brainstorming questions for the panelists, I do have one that I wanted to get into. Insurance coverage, as we all know, is a nightmare, and for these sort of rare disorders where a lot of drugs are not yet approved for these specific disorders can be really troubling. I know one of you mentioned that you were taking an EOE drug off label at the start. So I would just like to get a sense of what you guys think the importance of FDA approval is to obtain these medicines through insurance coverage. And I'm not sure if anyone wants to jump in and start with that question, but Dawn, do you have any input there?
Sure. I think it's absolutely important. One that was mentioned was Dupixent. We in the community, parents were just like, yay, when it was approved, because it was something that my son was both weight restricted and age restricted, and then the approval. And so certainly knowing that was something that we could say, okay, go, not go yet, but then go. And so this is something that we all watch and monitor, just as I think we heard in the previous session. You are not just watching the medications that are there, but what's coming next for treatment. So certainly it's important.
Absolutely. Heidi, did you have anything to add?
I agree, the FDA approval is very important. We've fought for quite a while to get it through, even under the dermatologist, because we had to prove that we'd failed all the other things we could do for eczema that we had been trying for years with big side effects. So we really had to struggle. And then just the cost, too, of these therapies. Dupixent's very, very expensive. Carly's lucky because she has Medicaid secondary, but not every child has that, and not every state is the same. So just making sure that medications then are affordable as well, because it can really be difficult to get the therapy they need with the cost of some of these medicines.
Yeah, absolutely. And then Jenny, I know there are no approved medicines for eosinophilic gastritis, but do you have any thoughts on what you would like to see out of these these clinical trials and these endpoints to see medications become more available?
Oh, definitely. I think that approval of medications is so important because it increases access. Clinical trials certainly are important because they're the way that medications get approved. And I think that not every patient has access to a clinical trial based on location and kind of ability to travel. So I'm really excited with all the clinical trials going on that EOG will have an approved medication hopefully soon. I think from a physician standpoint, it's interesting to talk to patients who have EOG because we do have treatments, but there's nothing approved. So it'd be really cool to be able to tell my patients one day that, hey, we have a medication that's finally approved.
Yeah, absolutely. And I think there's a question from the audience.
Yes. Thank you all for being here, sharing your stories. I agree, first of all, with the insurance approval. That is something I spent 2 solid months full-time trying to get something approved for my treatment. My question's about care coordination. So these diseases tend to be complicated, multiple subspecialists are involved. How do you handle coordinating care, communication between doctors, and making sure everything's covered at the end of the day?
Yeah, that's a great question. Does anyone feel strongly about taking that? Dawn, sure.
Sure. I was just making a few notes of the last 13 years journey, but certainly it's coordination of all the different doctors. So being in education by background, I would just create folders on the computer in the Google Drive, and then also physical folders for each of the providers. When he was having seizures, we didn't know what that was. When he was having the severe eczema, didn't know, and then there was EOE. I might add, we also created, my ex-husband and I created folders for school. So we were meeting to make sure that all the teachers knew no food in the classroom, make sure Joshua doesn't eat this. But more importantly, as I just cited, my ex-husband and I, Joshua was in the 2 homes as of when we divorced. Joshua was about 3 years old. And so we needed to manage between households, and it meant having a notebook that we passed back and forth when he went to mom's house and dad's house. It meant us collaborating with the providers, making sure that the doctors knew we needed 2 sets of everything, scripts and everything, information, and that we were communicating constantly. To this day, we make sure there's a stat emergency, we're in ER, to notify the other parent, but also for Joshua to be a self-advocate. So I do think it's very much a coordination of a team, and making sure that the providers are coordinating one with the other, our eczema provider, dermatologist, knowing to coordinate, obviously now with our Dupixent, with the GI doctor. So it's a give and take, but it's a learning process. There is no roadmap. Certainly this journey is evolving as I speak. And so I think it's just being able to know how can you open yourself up to providers. I might say also enlist not only your case manager with your insurance providers, but also the hospitalist. Different social workers can engage, and then your persons in your school systems to be advocates for you.
No, that's absolutely so important, the self-advocacy, but also the amount of organization that goes into managing someone with EOE or even yourself with one of these disorders. So I'm glad Joshua has been set up so well to handle all of that. Deb, you've mentioned your eosinophilic asthma, so as someone who's recently probably had to expand your care team, could you comment on this a little bit?
Yeah, so I do the folders too. And also we have 2 calendars. We have the home calendar, and then I have my own personal calendar, which I walk around with just like you. The problem is just trying to manage the different doctors, and I think the main problem that I've experienced is trying to have the allergist deal with and talk to the GI specialist. And right now I'm in between GI specialists because mine left the group for retirement, and now I'm waiting to get on the calendar for the new person. I trust that the new person knows EOE. I've done my research with that, but that has been my biggest challenge right now. I've found a really good pulmonologist. So I've gone through all of the steps with him, and actually that has been going very well. So now we're just looking at pulmonary tests. I'm waiting for an appointment there. But trying to get appointments with these specialists is like, it's killing us. It really is. It's terrible. And you can't get a live person who actually gives you that care, that says, I understand what you're dealing with, because it's just another person on the end of the phone that wants to get to the next call. They want to wrap up your call so quickly, get to the next call, and they don't have the information, they don't have the background. So that's what I've been experiencing with challenges lately.
Yeah, the managing medical care, I mean, all these different facilities are, it's so tricky to, if you're between facilities, manage all of your different physicians, and even within one facility, unless the care team is really coherent, it can be so difficult. So I'm glad you have the folder system. Hopefully that's helping kind of keep everything together. Heidi, what about you? Do you use a bunch of folders as well to try and manage all of this?
I used to have a notebook, but I don't anymore. Life gets crazy. But one of the biggest challenges we had was with other conditions. Carly had chronic constipation as well, which isn't typical, I guess, with EOE. So finding a doctor that would deal with her encoparesis and the EOE was really challenging. We had a great team at CHOP, and that's one good thing. If you can find a team, like an allergist and a GI that work together, that's amazing. And then we still see another GI doctor because he was the one that diagnosed her. So we have the team at CHOP, and then our GI that we have seen since Carly was born. And then we have had a team at Hopkins. So we had to go south to deal with the south end and northeast to go with the upper. So it was really hard. And then when it came time for her to get her feeding tube, when they finally acknowledged that she was failure to thrive after many years of fighting, they decided at the same time that she needed a cecostomy, which looks like a feeding tube, but it flushes your colon. It's an enema that you give through a G-tube device. So there was some tension then between CHOP and Hopkins, who was going to place it. CHOP wanted to place the G-tube. Hopkins wanted to place the cecostomy, and then the Hopkins doctor wanted to place both because it would be one procedure and it made sense. But then there was some hurt feelings at CHOP because they had decided they wanted to do it, and they had a whole plan. She'd be admitted for a week on a G-tube feedings, and Hopkins she doesn't need that. So there was a lot of tension there. So it can be really hard to manage, especially if you have other conditions as well. and then just finding doctors that'll work together. Because getting doctors to communicate outside of that clinic at like CHOP has been really hard. It's hard to get doctors to talk to each other. They're very busy. So that was challenging.
Yeah, having that care team all in one place can really, especially I feel like as a pediatric patient, that was something that was very helpful to me. So I'm glad you guys have that at CHOP, and even with that, there's still so many challenges to overcome. I think we have another question in the audience.
Yeah, hi. Heidi, I related with your story a lot. My son was 36 pounds at 8 years old, but we had a diagnosis. But I wanted to ask you if you could expound a little more on how you got the doctors to help with the chronic constipation.
That was so hard because we dealt with the encopresis, that frequent stooling, for so many years. It was so traumatic for Carly and for us because she would have accidents all the time and she would be smelly. We're still struggling a little bit with it. So we talked to CHOP about it quite a bit, but they never quite acknowledged it because their focus was always the esophagus. So they finally have a doctor now that's dipping her toe in it a little bit, but we ended up just having to go out of system. The hospital that I worked had a collaboration with Hopkins, and we had to go through a general surgeon that was dealing with constipation. So just finding a doctor that's familiar with the chronic constipation issue would be key. Dr. Nasser was doing a lot with the cecostomies and the appendocecostomy, where you take the appendix out through the belly button and then you can flush there. That's another way that they can do it. So just finding a doctor willing to do these kind of surgical procedures. And we also had to do the test for Hirschsprungs. We had to do enemas, which were horrible, for several months, where we would have to prove that we could get her colon clear. So she was, I guess, around 5, which you can't explain to a 5-year-old why you're doing these enemas and have them truly understand. So just the trauma of dealing with having to do these enemas. I remember her laying on the bathroom floor and just screaming and having to hold her down. It was awful. And then issues in the public restrooms where you have a kid screaming and you're just trying to clean them up and change them, but it sound to anybody that would walk by, it would sound awful. My mom and I were always so stressed whenever we had to clean Carly up in public. But if you can find a doctor, probably some sort of general surgeon that's dealing with constipation would be your best bet to find somebody that could manage it. Now, Dr. Nasser's in Hopkins, and he has a team, but even then it took a while to really get the constipation under control. And now we're on, is it Eliquis? We're on a medication that releases fluid into her colon to try to help with the constipation issue, but she doesn't like it, and it's causing some leakage again. We did Senna for a long time. Constipation's tricky. It's almost been harder, I feel like, than dealing with the EOE, because it's more noticeable to everyone on the outside if you're smelly or having those kind of issues. And it's been a challenge with school too.
Yeah, thank you. Thank you for sharing. I think that's a really interesting point, kind of the visibility of some of these disorders. I'm sure we've all heard over the years someone like looking at your child or yourself and being told, "Oh, well, you look fine. You don't visibly seem sick," and that's, it can be disheartening to hear when you're struggling with like all of these things internally. And you brought up the difficulties at school, and I'm sure that continues into adult life with work as well. Deb, would you like to share anything about managing these in the workplace?
Yeah, work had been really difficult. I'm retired at this point, but it was getting harder and harder as I got older, especially these last 10 years. And I had a job that was, I always called it 24/7. You would definitely put in like the 12-hour days that were just so intense. And if I had a day that I struggled, where I always called it the quicksand day, it just was like, put your foot in front of the other and just get going. But it was a sit-down job, and it was hard. You know, it was very difficult to get my lunch, and it takes time to do the lunch. It's not an easy lunch. So I always tried to prepare things ahead of time, but again, the job would get in the way because it was just so busy and so intense. So I really struggled with it. You know, tips for it is to just try to plan ahead with food. And you know, when I was traveling, it was hard. Not that I traveled a lot recently, but in my early days of EOE, I was actually asked to go to Japan. And I turned it down the first time because I was just so sick. And I thought, how am I ever going to get through that travel? And then eventually I did, but it was so difficult. You know, I would be sick on the plane, I would be sick in the hotel and in meetings. But, you know, I got through it because I wanted to. It was something that I really wanted to do for my life. I love to travel, and I love to teach people. And my Japan trip, for example, was a teaching opportunity that I really didn't want to put down. But it wasn't easy.
Yeah.
And I don't miss it.
Jenny, you're in kind of a unique situation where your work is kind of in the same field as you know, your eosinophilic gastritis. Can you talk a little bit about having to manage EG while, you know, working with EG patients?
Yeah, I think that I want to echo what was mentioned before. I think one of the struggles for me is definitely food. Working in an office environment, there's often food around, and like people will bake things and they'll offer them to me and I'll say no, and they'll be like, oh, you don't want to try it. I don't want to offend people, but at the same time, like I don't necessarily want to make like my disease like the first thing that someone hears about me. So I felt like that was an issue for me, like saying no and just not feeling bad about it. I think one of the things I struggled with in the beginning was like going out to eat because I wasn't used to asking so many detailed questions about menus and food. And I felt like I was a burden to the people eating with me, and I felt like I was a burden to the restaurants. But I think with time, I've gotten more used to just advocating for myself. In terms of working with patients, it's given me a very like interesting and unique perspective, because when I meet patients, I talk about the different treatment options, but I really emphasize how important it is to make a personalized decision. And when patients are interested in talking about elimination diets, I really emphasize how hard it is. Sometimes I do share with my patients that I have EOG. I think it depends on, you know, whether or not, you know, based on our conversation, I feel like it would be helpful to the discussion or helpful to that patient-doctor relationship. But I think it does give me a unique perspective, because I feel like when I bring up food restriction, having personally gone through it, I know how hard it is, and I can kind of speak to it with a little bit of more understanding.
That's so important. I remember being told by my doctors, like, oh, just stop eating all of your foods. And it's like, well, that's not a very fun thing to do at 13. And, you know, I think it's great that you have that experience to be able to relate to your patients a little bit more. Dawn, I saw you nodding along. Do you have some additions from...
Yes,
Yeah.
Scribbling down notes. This is great information, but it's almost like you're all living same lives. Being able to travel, we go out to see my parents every year out west in California, and so as you can imagine, we're not jumping on an airplane and eating airplane food or going to the food court. In fact, we avoid all food courts. The smells offend him greatly. He can't eat the food, and now he is certainly curious about what is a Nathan's hot dog, or what are these general foods that everyone enjoys that he can't eat. He still has a restricted diet of about 20 safe foods that keep him out of the emergency room. So we travel safely. We ship things ahead. When we travel, for example, I can send along the canisters of his elemental formula. a la overnight. I have some of his food shipped directly to my folks' house, but more importantly, when he goes to camp, like he's gone this summer, he loves to play basketball and soccer like every kid. But he needs to go and do his bolus feeding. And so making sure the camp knows he needs a safe place to have his lunch, which is his bolus feeding, as opposed to him eating the food. He does not always have an appetite, even when it's time to eat. So from the doctors and others, we don't force him to eat. We'll say, great, are you hungry? I like to echo what was also shared about making sure that we just be really safe. I mean, family events, holidays, I've convinced my family and my ex-husband's family about, hey, holidays are not about food, it's about fellowship. And so it's not just, here's the big meal, everyone partake, because he has the food restrictions we celebrate. And if food is part of it for others, we keep that in a separate area so it's not offensive. It's just a mind shift. And certainly I think, as I've heard said, it's the theme of us all learning to shift our lifestyles accordingly, and then sharing answers, getting the cool backpacks that are refrigerated. I think there's another young man about Ryan's age who travels with a refrigerated backpack for his medication. We're like, ooh, where'd you get that? So we're all like, how do we do that and share answers? So it really becomes a collective experience.
No, absolutely. That's one of my favorite things about growing up at the APFED conferences, just learning from everybody else, because everyone has such a unique circumstance, but there are just so many tips and tricks that have been shared among us all that have been so helpful. Heidi, I wanted to circle back to you. You've mentioned this issue that your daughter has with chronic constipation. Has there been any insight as to what might be the cause of that? Do they think it's EGID related or diet related? Do you have anything to add there?
I don't think they've ever really determined. It's been something that she's had issues with her entire life. So the medications, Linzess, sorry, I said the wrong medication earlier. We've tried so many different things. This acostomy was what worked the best, but she didn't enjoy getting the flushes. So we haven't done them in about a year or so, about as long as we haven't used the feeding tube. But now just keeping it under control. We have fairly good results compared to what we used to, but still not 100%. So I wish we had a definite answer. They just have called it idiopathic. So it's definitely been a challenge for her whole life.
Absolutely. It can be so frustrating when you know that there's something wrong and you just cannot get the answer from a physician. Do we have another question from the audience? Oh, perfect, yeah.
Hello, so I am a patient with EOE myself, and I was interested that we have someone on the panel with an eosinophilic gastritis diagnosis, because I'm starting to wonder about that for myself as well, just because I do tend to have my primary symptoms. Of course, my esophagus symptoms are managed by swallowed steroid right now. I still seem to have a lot of the lower GI symptoms, like nausea is kind of my primary symptom. So I'm just interested to hear more about the experience of gastritis and the diagnosis, and if anyone on the panel knows anything about that intersection of the esophagitis and gastritis relationship there.
Yeah, Jenny, this would be a great time to tell us about your first signs that something was wrong and some of your diagnostic process.
Yeah, so some of the first symptoms that I had was I had something called early satiety, where I would eat a little bit and then feel just very full and not want to eat. It happened to me initially. I remember having a lot of nausea symptoms and just feeling unwell. I've never really been a person with a lot of reflux or heartburn, but that started happening to me. I remember I started carrying around a bottle of Tums to work, and I just thought it was stress from work. And I remember it was particularly stressful months, but I thought it was stress, but I felt very nauseous, very I had a lot of abdominal pain, epigastric pain and lower abdominal pain. I had diarrhea actually for a bit of time. And the thing that kind of tipped me over the edge was I remember one day when I was off from work, I had an episode of like projectile vomiting. So I think up until that point, I just thought that all of these symptoms were stress related. But when I had that vomiting, I was like, this is something that's not right. So I went to my primary care doctor and I told her about my symptoms, and she did some blood work. And they found pretty high eosinophils on my blood work. So I was referred to see an allergist and a gastroenterologist. And so the allergist did some additional blood work to see if I had any sort of like hypereosinophilic syndrome, which I didn't. And then I ended up getting both an EGD and a colonoscopy with the gastroenterologist. I think one of the hard parts about eosinophilic GI diseases below the esophagus is that currently for adults, there's no like set diagnostic criteria. Earlier this year, the criteria were published for pediatric patients, but certainly when I was diagnosed 3 years ago, there were no published criteria. So I think the diagnosis is a little bit hard because we don't have set cutoffs like we do in EOE, where it's like 15 eosinophils per high powered field and you get the diagnosis. So I think that's a struggle with regards to the other eosinophilic diseases, but I think like the data is certainly coming. I think one important thing is like if you're having these symptoms as a patient, to really reach out to your doctors to kind of advocate for yourself. If you feel like something is not right, and I felt like something wasn't right, just reaching out, voicing that and trying to get in to see the specialist who can do the procedures and make the diagnosis.
Yeah, just to add to that, I agree with what Jenny said. I had a lot of nausea with the EOE at the very beginning, to the point where my husband, I'm looking at him now, he couldn't even cook in the house. We actually had to put a stove outside in the garage. So anytime that the kids and him were eating, I would just book upstairs. But all of a sudden, like, the nausea went away, and I would get it periodically. But I never had abdominal issues. Like, I didn't have cramping or anything like that. Do you have a good GI doctor?
I do have a good GI doctor. I have a great GI doctor, actually.
Oh, good.
And it doesn't, I don't think I'm having the full range of symptoms that Jenny has experienced. It's just lately, that seems to be the biggest issue. And I've noticed that the nausea, again, it was definitely associated with my EOE symptoms. And right now, again, I'm on the steroid. I still have to avoid all my triggers. As of now, I know of like 40-something food triggers, so I avoid all of them. And it's just recently, in the past few months, that despite avoiding my food triggers, I'm still experiencing like this nausea, like pretty intense. I don't know if the vomiting, but intense nausea pretty often. But again, not the cramping and stuff. So it sounds like just, connect with my GI doctor, but it helps to hear that you also experience the intense nausea only with the EOE.
Yeah, and it was that intense nausea was at the beginning, but I do get it periodically, and I notice that it's when my body's depressed. So if I have a cold, or my allergies are really peaked from the outside, or from a food that maybe I chose to cheat on, right? So it may raise its ugly head at that point.
It also helps to hear, because just knowing my history of the past few months with sickness and life stress and that kind of thing, it would make sense.
Yeah.
So yeah, it helps to hear your experience. Thank you.
Yeah, the stressors, whether they're external or internal, can really, wreak havoc.
Yeah. Oh, we have another question. Perfect.
Hi, I'm mostly a caregiver, but I'm curious about the phenomenon of continuing to experience symptoms when the endoscopy looks good. Has anyone had that kind of experience?
Yeah, that's me. The endoscopy, I haven't had one in a long time because I haven't needed to, but I still have issues. Not bad though. You know, like I said, I'm one of the lucky ones, but I'm not convinced that you're going to see the EOs in the blood and in the gut or the esophagus when you still have symptoms.
I have one more short question, if that's okay. I'm curious about seasonality, like if you see a trend or kind of cycling with the seasons that might have to do with kind of an environmental trigger, pollen or something like that, when you have all the food triggers eliminated, like what else might be triggering things and what you might be able to do to manage that?
I could take that. Yeah, so I struggle with that all year. And I have allergies that get picked from the pollen or anything environmental, including molds. So the molds is my problem all year round. So I know after tracking through a spreadsheet or whatever, I know when my peaks and valleys are. So I tracked things for at least 2 years, and now I know February is my worst. Also in August can be bad, as well as in April, May when the pollen is bad. So I know to look out for them, and I've been still playing around with the antihistamines, you know, which one works then and which one works now, depending on whether it's pollen or mold, and I still am playing that game, but it seems to be helping. I'm definitely getting better, and I don't have as many quicksand days. But those environmental triggers are really bad for me.
I would ditto that. I was nodding my head when you were sharing about molds. The time of year where we live in Central Virginia, the fall with the leaves and that transition period, it's almost like he flares and the fall is the worst. He'll be lay out sick. And then we have the asthma that can flare. He can get croup. He's had bronchitis and pneumonia several times, hospitalized, because those are immediate. I mean, it's almost like a small cold. Everyone's cough, and then next thing you know, there he is, bronchitis, and they're wheeling him upstairs like, oh, it's actually pneumonia. I do think that we do try to be aware of the trees and pollens, bad weather days, all of that, but also when there are sickness floating around, to be especially aware. I know I've asked him about wearing his mask more so because of the things that he can pick up easily. He's 13, so of course the answer is no. But I'm like, yes, please, because we know what time of year it is. So I would absolutely echo the seasons, as well as some allergic reactions for like different foods related to, it's just like, wait, yes, it's tree season for XYZ. Of course he's having a reaction, so.
But you still scratch your head every once in a while, right?
All the time. I make notes on everything because I'm like, the correlation. No, every fall, September, now here it is. Leaves are getting to be, or maybe more so October, November. And then invariably December, we're like, hello, emergency room, you know, with a respiratory issue. Again, he has different conditions related to the EOE. And then I think just monitoring it, you start to track it. And once you keep a little journal of, this happened the same time last year, monitoring so that you can be prepared.
And then Dawn, I'm curious, after the dupilumab, you said Joshua started that back in January. Has he been scoped yet on the dupilumab?
Yes, someone just mentioned about the scope. So Joshua's had an interesting scope, and I know some of his team will be here at the conference, so not divulge anything, certainly out of line, but he had a scope, but apparently still has reflux and issues that even though he's now had the dupilumab, which are for him injections in the tummy, he does not like it at all, weekly. I know there are lots of different ways, and for those who do have that, it was the option. We did choose for him to have that. But he has been now put back onto a Nexium because apparently, and he can't tell us that he's having any sensations of burning. We don't know. Again, it's an anomaly, thinking everything should be great, right, with the dupilumab, the Dupixent. And also because of the different areas of his cycling, we don't quite understand yet. But hopeful, since we've been on it just now, not quite 6-7 months, that we'll have some positive outcomes from that.
Yeah, fingers crossed. I think we have a few more minutes, and we had one more audience question.
I didn't have a question. I didn't have a question, but I wanted to make a comment. I have asthma, and the allergist that I went to as an adult told me that allergies can affect all of your body symptoms. He said that depending on what you're allergic to, it can make you feel tired, can give you flu-like symptoms. So I was wondering, maybe with eosinophilic disorders, if it's the same thing, that like certain times of the year you feel worse than other times, that maybe it's the same thing.
Yeah.
It's affecting all of your systems.
Yeah, Heidi and Jenny, do you guys have any experience with these sort of seasonal, more environmental allergies impacting your EGIDs or your daughter's EGID?
I don't think with Carly we've seen a whole lot of seasonal fluctuations, at least not recently. The Dupixent has her EOS pretty well under control, but she does complain about being tired pretty much all the time. If you ask her how she is tired is her default answer, and we do wonder, is she really tired? Or is that just her answer to everything now? But, I mean, she's not a big complainer, but tired has been something she said quite a bit. So I don't know if maybe that could be a little bit of that she really is tired all the time. She will take a nap. At 14, that's not, super common for most kids. So.
And then Jenny, I know allergy or these sort of hay fever and these other allergies are more of a comorbidity for EOE. But have you had any experience with EOG and these more seasonal environmental allergies?
So I have environmental allergies on top of the EOG, and I really haven't noticed a seasonality with regards to the EOG. I do notice that when I've had flares of my EOG, I do feel more fatigued and more tired, but it's more so that I've been accidentally exposed to my trigger or things like that. But I haven't noticed just a seasonality with regards to the EOG.
It's so wonderful to have all of you patients and caregivers here to share your experiences. I know it's something that personally for me was very impactful growing up, so I hope everyone online and in person was able to take something away from this. If anyone does have any other questions or wants to chat afterwards, I won't offer everybody else up, but feel free to reach out to me, and I'm sure all of our panelists would be happy to chat as well. And with that, let's give everyone a round of applause before we introduce my speaker. Thank you. Perfect. Just while we're transitioning, next up we're going to have a talk on the FDA approaches to eosinophilic diseases by Dr. Kowalik. Dr. Kowalik is a pediatric gastroenterologist by training and a clinical team leader in the Division of Gastroenterology at the Food and Drug Administration, the FDA. Dr. Kowalik's team reviews applications for a variety of gastrointestinal disorders, including inflammatory bowel disease, eosinophilic gastrointestinal disorders, gastroparesis, and gastroesophageal reflux disease. We are excited that he is here today to talk about FDA approaches to eosinophilic diseases. Please join me in welcoming Dr. Kowalik.
Okay, I think we're all set up here. All right. Thank you. Thank you for the introduction. Good morning, everyone. Again, my name is Matt Kowalik. I'm a pediatric gastroenterologist and a clinical team leader in the Division of Gastroenterology at the Food and Drug Administration. I just wanted to thank the organizers for inviting me here today. Very happy to speak with you. about drug development in eosinophilic disorders, the FDA perspective. We've had a lot of great collaborations in the past with APFED, which I'll sprinkle in today in my talk. And as Mary Jo mentioned, this organization really helps to move the scientific field forward through advocacy work, grants, and meetings like this. So I'm very happy to join you today. Okay, this is my disclosure slide, but I'm not really going to read it. So this is what I'd like to cover today. I asked to cover a couple of these points. So I'll start by just introducing the Division of Gastroenterology and the Food and Drug Administration in general. I'll go through our mission, some of our organizational structure, and I'll mention some of the indications that we manage in our division. And then the bulk of my talk will be talking about how we work with stakeholders to advance drug development, and there's many ways in which we do that within a specific drug development program, through guidance documents, and through other external outreach activities. I'm also going to talk about patient-focused drug development and FDA use of patient experience data, which is an important part of our regulatory drug reviews. And then I'll use an example to go through some of the regulatory considerations for new drug approvals. So I'm going to start by introducing the Division of Gastroenterology. And first, I just want to talk about what is the mission of the FDA. And we are responsible for protecting the public health by ensuring the safety, efficacy, and security of human and veterinary drugs, biological products, and medical devices. And for a new drug to be approved for marketing in the United States, the FDA must determine that the drug is safe and effective for use under the conditions prescribed in the labeling. And we're also responsible for advancing the public health by helping ensure the public gets accurate science-based information that they need to use medical products and medical foods to maintain and improve their health. Similarly, the Division of Gastroenterology has sort of similar commitments, but focused on the patients that we serve. And it's our mission to facilitate development of safe and effective drugs that are intended to treat gastrointestinal disorders as expeditiously as possible. And our ultimate stakeholders are many of you in the room, patients, their families, and we incorporate the experience of patients and families to enhance understanding of each of these diseases and foster creative approaches to drug development. And we collaborate with multiple stakeholders, patient groups, academic community, therapeutic developers, other regulatory agencies, all to facilitate development of promising therapies for our patients. Okay, and now I'll just kind of orient you where the Division of Gastroenterology lives within the FDA. The FDA is an agency within the Department of Health and Human Services, and that's part of the executive branch of the U.S. federal government. We're a very large agency, as you can see with this flow chart, and the Division of Gastroenterology is located inside the Center for Drug Evaluation and Research, or CDER, which I've circled here. CDER provides regulatory oversight of drugs and therapeutic biologics. And so if you're thinking about other things like fecal microbiota transplants, vaccines, cellular, gene therapies, tissue-based products, those are reviewed in a different center, the Center for Biologics Evaluation and Research, or CBER. And devices such as endoscopes or certain tests like breath tests are managed through the Center for Devices and Radiological Health. So within CDER, the Division of Gastroenterology is located in the Office of New Drugs. And this office provides regulatory oversight of new prescription drugs and therapeutic biologics. There are several offices within O&D, and our division is located within the Office of Immunology and Inflammation. And in this office, you'll find other divisions that review other eosinophilic disorders that involve other organ systems, such as the Division of Dermatology and Dentistry and the Division of Pulmonary Allergy and Critical Care. And here are some of the indications that we manage in the Division of Gastroenterology. So you see, just like gastroenterology as a subspecialty, we cover a broad range of indications, from inflammatory bowel disease and eosinophilic gastrointestinal disorders to short bowel syndrome and bowel cleansing agents. So now that I've sort of oriented you with where the Division of Gastroenterology, or DG, lives, I wanted to talk about how we engage with multiple stakeholders to help drug development. And so to do that, I'd like to just kind of very broadly take you through the whole drug development process and drug development life cycle. So this is a graphic that gives a very broad overview of a drug development timeline. And this is just a very high-level example, so it may change depending on different drug development programs. But I wanted to use this to help sort of frame how we at the FDA interact with individual drug developers. The first two stages, the basic research and drug discovery, often occur before interactions with the FDA, but we do have programs to support engagement with stakeholders even at this early stage. Preclinical work begins before a new drug or biologic is tested in humans, and the goal is to determine whether the product is reasonably safe for initial human use and is sufficiently effective against a disease target using chemical assays or animal models. We often meet with stakeholders during this phase before even an investigational new drug has been opened, called pre-IND meetings, and this can include a variety of topics where we might talk with developers about what studies they need to do before starting trials in humans, as well as talk to them about their overall drug development plan. Then before clinical development and studies in humans can begin, a developer needs to submit an investigational new drug application, or an IND, and the IND submission contains information to support starting studies in humans. This includes pharmacology and toxicology studies, manufacturing information, and clinical protocols and information about clinical investigators. This IND submission is reviewed by a multidisciplinary team, and it's determined whether the IND is safe to proceed, and if not, the IND may be put on hold to prevent using the drug in humans until identified deficiencies have been addressed. The next stage, typically referred to as phase 2, has a goal of establishing initial efficacy in the patient population. It's also time to characterize pharmacokinetics, or how the drug interacts with the body, as well as the safety of the drug. During this stage, we meet often with developers to discuss the design of their phase 2 studies. We also review study protocols and provide advice and feedback on those. And developers can also request an end of phase 2 meeting where they finish their phase 2 study, they provide us with the results, and we discuss their plan for future studies that may support a future marketing application. The next stage, often called phase 3, is when clinical trials gather the data necessary to support a new drug application. And in order to do that, they have to demonstrate that the drug is safe and effective. And I'll be going into this in a little bit more detail. Once the phase 3 program is complete, we often have meetings that are called pre-NDA meetings, or pre-new drug application meetings, and that's where we discuss the strategy with the developer to submit a new drug application. Then the developer will submit a new drug application, and it contains all of the human and animal data from their development program in order to support the safety and effectiveness of their drug. And during this NDA review phase, a very large multidisciplinary team reviews all of the information, ensures that it's complete, and determines whether effectiveness and safety has been demonstrated. And then our role interacting with stakeholders doesn't end after a new drug is approved. In the post-marketing setting, we're monitoring for safety. There are many databases that monitor safety because now you have the new drug being used in a larger number of patients. And so if new safety signals are identified, we have mechanisms to take action as needed. So that's sort of how we interact with individual drug developers as they work within a specific drug development program. But we also engage with multiple stakeholders outside of a single development program. One way which we do that are through FDA guidances. And a lot of people may not be familiar with what that means, but I'm going to go over a little bit what a FDA guidance document is. But first, I want to sort of touch base on where FDA authority originates, and it's from statute. And so statute are the laws written by Congress, and it sort of lays out, and I'm going to give an example later, sort of the basic requirements of what Congress wants to see in order to, in this case, support a drug approval. For example, the Federal Food Drug and Cosmetic Act was passed in 1938, and that is the beginning of FDA's authority to oversee the safety of food, drugs, medical devices, and cosmetics. So those are statutes, and then underneath statutes are rules and regulations. And so those are originate from FDA or other agencies that are interpreting the statutes. And these provide, a little bit more detail as far as what the statute is expecting. And these regulations are legally binding and enforceable, and FDA regulations are described in the Code of Federal Regulations. And then there are guidance documents, and although these are outside of the legal process, they're not legally binding, they play a vital role in our dialogue with multiple stakeholders. So a guidance describes the agency's current thinking on a topic, and so it may assist sponsors in designing their drug development programs, or it may inform sponsors and other stakeholders, what we think about a current regulatory issue. They also help to leverage communication between other regulatory agencies, the academic community, and of course, the pharmaceutical groups. And so we've published several guidances in the last few years, including guidances on eosinophilic gastrointestinal disorders, particularly eosinophilic esophagitis. And I'm going to be talking about this more. But these guidances really come about after we've engaged multiple stakeholders, and they help to lay out our current thinking on, for example, for EOE, drug development, and selecting endpoints and things like that. There are even more different opportunities for engagement with external stakeholders. We've held several patient listening sessions. Some have been patient-led, while others have been FDA requested. And these sessions recruit patients to tell us about their experience with their particular condition. And it provides us with a lot of important information to hear about the experience and perspective of patients and what is important to them related to their condition. We also engage in discussions with multiple stakeholders during FDA-sponsored workshops, such as the Gastroenterology Regulatory Endpoints and Advancement of Therapeutics, or GREAT, workshops. The most recent one is in July of 2021, which was a 2-day event which focused on celiac disease as well as eosinophilic gastrointestinal disorders beyond EOE. So I'm going to talk more about that workshop in the next slide. So I had the pleasure of being part of this workshop where we discussed the eosinophilic gastrointestinal disorders beyond EOE. We had a huge group of multiple stakeholders, included academia, pharmaceutical companies, other regulatory agencies, and patients. And it was a really great opportunity for us. We covered a lot of ground. We discussed a lot about disease characteristics, natural history, and assessment of clinical benefit. It was also a great opportunity for us to hear from patients as they presented during the workshop. And since then, the scientific advances in EGID beyond EOE have continued, which we're really happy about. Some examples of this are an international consensus on just defining EGIDs. There are different regions that may be involved in EGIDs other than EOE, as well as characterizing symptoms, pathophysiology, and as was mentioned earlier today, some of the thresholds for when you might think too many eosinophils are present in an area. A lot of research has been done on that since the workshop. So I'm going to shift gears again a little bit and talk about patient-focused drug development, as well as the use of patient experience data. And APFED is very involved in this sector, but just as so many of you may already be aware, but patient-focused drug development is a systemic approach to ensure that patient experience, perspectives, and needs, as well as priorities, are all captured and meaningfully incorporated in drug development, as well as during the review of new drug applications. And we really believe that this is an important part of drug development because we really want to make sure that when we approve a drug, patients are feeling better because of that drug. So here's an overview of some of the areas that you can integrate patient input during drug development. And you can see, it starts as early as the preclinical phase, identifying and measuring outcomes and symptoms that are meaningful to patients so that you can assess those in clinical studies once you open an IND and start doing the clinical trials. And information directly acquired from patients is a key component of our overall benefit risk assessment when we review a new drug application during the pre-marketing review. And once a therapy is approved, it's also important because it continues to help us ensure, that the therapies are meeting the needs of patients, and it also allows patients to make informed decisions when starting, continuing, or stopping therapy. And over the last 10 years or so, there's been a lot of growth and interest in integrating the patient's input, and one way in which you can do that is through patient-focused drug development meetings that are externally led, so not dependent upon FDA, but often formed by patient collaborations, including APFED has held one, I believe, for hyper-eosinophilic syndrome. These externally led patient-focused drug development meetings provide an opportunity to hear from patients directly, patient advocates, caregivers, about what symptoms matter the most, what the impact of the disease is on a patient's daily lives, as well as experience on currently available treatments to identify gaps in treatment. And while FDA often attends these external-led meetings, at the end of the day, they are not considered FDA-sponsored. But it's sort of a disclaimer that I have to say, but we do value these a lot, and I'll show you on the next slide. We use, when we have available externally led patient-focused drug development meeting summaries to help strengthen our understanding of disease and treatment burden. It really helps us develop a therapeutic and clinical context. And our FDA staff really rely on these when we're reviewing a new drug application for that particular indication. And you can find summary reports of externally led PFDD meetings on our FDA website. There's a link here that you can access, or you can just Google it. It's pretty easy to find. And again, I think there was a hyper-eosinophilic syndrome PFDD held by APFED in 2018. Although I don't review those, the other division that does review those relies on the PFDD summary meetings when they're involved in drug development. Of course, there are many other ways in which patient voice can be incorporated in our drug review process. Recently, the FDA has finished a four-part guidance series on patient-focused drug development, geared more towards drug developers, but lays out the strategies to identify what symptoms are important for patients, strategies to ensure you're measuring that appropriately, how to measure a meaningful change so that a change shown in the clinical trial actually represents that patients feel better, and things like that. So that was a huge accomplishment. And we also have pilot grants for developing clinical outcome assessment measures. These are surveys that are used in clinical trials that assess a patient's symptoms. There's just been a general increase in focusing on patient input in pretty much all of our endeavors at the FDA. So in addition to this, this has actually been codified as part of statute. So in the 21st Century Cures Act of 2016, patient experience data was included and defined, and it was required that it's used in our new drug application reviews. And so I probably won't go over this slide. It's very similar to what I've already talked about, but incorporation of the patient voice in our drug reviews is something that we do now, consistently. Okay, so my last topic is talking about some of the regulatory considerations for a new drug application review. So I've talked about some of our framework that we use, and I'll use an example of recent approval. We've heard it a couple times, dupilumab for eosinophilic esophagitis. And I hope that it'll sort of bring together all of my previous comments so far. So I mentioned the statute regulation guidance sort of framework. And so I wanted to bring us back to when we get a new drug application, what is it that we're thinking about when we are doing our benefit risk assessment and determining that it's effective and safe? Well, it wasn't actually until 1962 that drugs needed to be effective in order to be FDA approved. So there were some drug amendments to the Federal Food, Drug, and Cosmetic Act at that time. And again, it required that drugs demonstrate effectiveness in addition to safety to support marketing approval. And the statute lays out that effectiveness is established by substantial evidence. And so what is substantial evidence? The statute describes substantial evidence as evidence consisting of adequate and well-controlled investigations, including clinical investigations, by experts qualified by scientific training and experience to evaluate the effectiveness of the drug involved, on the basis of which it could fairly and responsibly be concluded by such experts that the drug will have the effect it purports or is represented to have, under the conditions of use prescribed, recommended, or suggested in the labeling or proposed labeling thereof. It's a whole mouthful. That's legal statutory language for you. So what exactly does that mean? There's a lot of words there that could be defined in multiple ways. And so FDA regulations have sort of broken that down into, what are the characteristics of an adequate and well-controlled investigation that we're talking about. And so that's listed in the Code of Federal Regulations, where an adequate and well-controlled investigation, has these kind of components. And this is, we're talking about clinical trials here. They need to have, a clear statement of purpose, appropriate control so you can make valid comparisons, appropriate selection of patients with the disease or condition. You're enrolling patients who have the condition and not some other condition. Appropriate assignment of patients to treatment and a control, adequate measures to minimize bias, well-defined and reliable methods of assessing response, as well as prospectively planned analyses. And I'll just bring it back to incorporating patient voice, the reliable methods of assessing response. That really gets at using, most often clinical outcome assessments, where a patient is directly asked about their symptoms, and it's measured, and that's part of the endpoints of the clinical trial. Okay, so bringing it back to eosinophilic gastrointestinal disorders, for eosinophilic esophagitis, there was, a pathway of multiple stakeholders working together to get to, sort of where we are now and where we're going. Back in 2012, there was a great workshop about eosinophilic esophagitis. In fact, APFED was part of that workshop. And a lot of that discussion during that workshop was about endpoints for clinical trials. And we heard a lot about the patient experience to identify, what symptoms are important and should be targeted in clinical trials. Then I mentioned there was a guidance for EOE, which was published in 2019 in draft form and then finalized in 2020. And I'm going to go over what that guidance talks about. But shortly thereafter, in 2022, we were very happy to approve the first drug for the treatment of EOE, dupilumab. And its label was recently expanded this year to include pediatric patients 1 year of age and older. And also this year, budesonide oral suspension was approved for 12 weeks of treatment of EOE in adolescents and adults. So now I'm just going to touch on the dupilumab program at a very, very high level to get a glimpse of how, these gradual advances led to the first drug approval for EOE. So as I mentioned before, the EOE guidance was published in 2019 and finalized in 2020. And I'm focusing mostly on the recommendation that we made to assess co-primary endpoints to support the efficacy of a drug for the treatment of patients with EOE. And I'll spend a little bit of time talking about these. So the co-primary endpoints included an improvement in signs and symptoms compared to placebo using a well-defined and reliable clinical outcome assessment measure, as well as documentation of histologic response as defined as a peak eosinophil count of less than or equal to 6 across all available esophageal levels. So why are we talking about a co-primary endpoint? And what a co-primary endpoint means is that a trial has to win on both of those endpoints to be considered a success. And that's because statistically significant results on a COA endpoint on its own may not represent a clinically meaningful change. So not only were we recommending that the co-primary endpoint include an assessment of signs and symptoms of EOE, in the guidance we also specified that additional analyses using anchors, I'm not really going to get into that, but additional analyses need to be done to show that, if you show a change from baseline in the symptoms, that change is a meaningful change, so that an individual patient in the clinical trial feels like they improved. Because you're looking at these endpoints at a population level, so you may see a change that's statistically significant, but it might be very small, and so overall patients may not actually feel better. And then the intent of the second co-primary endpoint of histologic remission or histologic response was to evaluate a drug's effect on the underlying inflammation. And the most commonly used and well-characterized measure of inflammation in EOE is esophageal eosinophilia, and so that's where the change in eosinophils in the esophagus came from. But as we've heard earlier today, eosinophils, although they're a prominent feature and an important part of the diagnosis, they can vary independently from symptoms. And because of that, we've found that using co-primary endpoints gives us a lot of confidence that a drug is effective because it's attacking the underlying inflammation and patients are feeling better at the population level. And so these concepts, which we think were a really strong advance, because identifying which endpoints to look at in a clinical trial is probably the hardest part. These came through all of those previous interactions that I talked about, where we've incorporated input from multiple stakeholders, and including patients. So I'm almost out of time, but I will quickly go through some of the data from the dupilumab program when it was approved in 2022 for adolescents and adults. So it was approved based on a trial that had 3 parts. It was a multicenter randomized double-blind parallel group placebo-controlled trial. Parts A and Part B were the main portions that I'll be focusing on today. And so in Part A, subjects who had active eosinophilic esophagitis were randomized to dupilumab or placebo. And at baseline and then at the end of the placebo-controlled treatment period of 24 weeks, the endpoints were assessed, so endoscopy and symptoms. Aligned with the EOE guidance that I mentioned, the trial had co-primary endpoints with the proportion of patients achieving histologic remission and the absolute change from baseline in the subject-reported dysphagia symptom questionnaire score. Now, the symptom of dysphagia was identified as one of the most important and predominant symptoms of EOE based on patient experience data. And the DSQ, the COA measure that was used to measure dysphagia, was constructed according to the patient-focused drug development principles that I previously talked about. Part B was a completely separate part, basically identical to Part A, but included a lower dose arm. However, that lower dose arm did not show a statistically significant difference in symptom improvement. And so that is not the dose that was approved, and I'll be focusing on the dose that was approved, which is 300 milligrams every week. So here are the main results of the trial for the co-primary endpoints for Part A and Part B. The histologic co-primary endpoint in black showed a treatment difference of 57% in Part A and 53.5% in Part B. So this is looking at the proportion of patients who had a peak eosinophil count less than or equal to 6. For the symptomatic co-primary endpoint in blue, an improvement in the dysphagia score was shown in Part A and Part B, of 12 points in Part A and about 10 points in Part B. And what I'm not showing is those additional analyses that I mentioned before using anchor-based methods that helped us interpret that change of 12 and 10 in both of those parts represented a meaningful change to patients. So when you asked an individual patient whether they felt that they had improved, they had. So based on these results, as well as safety information, which I'm not really showing, dupilumab was approved as the first treatment for adult and adolescent patients with EOE. So I've covered a lot of ground, and so just to summarize some of the main points, The FDA is responsible for protecting the public health by ensuring safety, efficacy, and security of human veterinary drugs, biologic products, and medical devices. The Division of Gastroenterology helps to facilitate drug development for gastrointestinal disorders for our ultimate stakeholders, patients, and their families. And the Division of Gastroenterology collaborates with stakeholders throughout the drug development lifecycle through guidances as well as other external collaborations. And patient-focused drug development and patient experience data are important parts of our regulatory decision-making, and I talked a little bit about what those are. And new drug application reviews are reviewed according to statute and regulations to ensure that a drug that is FDA approved is safe and effective. So thank you so much for inviting me here today. On behalf of the Division of Gastroenterology, we look forward to continuing to collaborate with you and advance drug development further in the eosinophilic disorders. Thank you.
Thank you again to Dr. Kowalik. It was wonderful to hear about the FDA process. APFED has been very excited about the developments for eosinophilic esophagitis treatment options. Of course, as you mentioned, there was that 2018 patient-focused drug development meeting for HES, and more recently in 2021, we co-hosted one for pediatric asthma, including eosinophilic asthma. So we are very hopeful to see some safe and effective drugs moving forward for those rare disease subsets. Just a few notes before I release everyone for lunch. I know we're all getting antsy. Some of the APFED volunteers are planning a Family Feud-style game tomorrow after dinner in the Wisconsin room. We're inviting attendees on-site and virtual to answer the survey questions that will be the basis of this game. And there's a QR code up now to access those questions. For those of you on site, we will be doing lunch, and we'll have a buffet ready in about 10 minutes in the foyer area, just to the left of the registration desk. The lunch buffet does have ingredients labeled for you to review as you go about selecting what foods are safe for everyone here to eat. Then please join us back here at 12:30, so in about 40 minutes, for a special Lunch and Learn session. You're welcome to bring your lunch back into this room. That session is sponsored by Sanofi and Regeneron, and Dr. Ruchi Gupta will join us from Chicago to discuss the intersections of EOE and food allergies. I think those are all of the main notes that I have, so please feel free to take a bit of a break, and in about 10 minutes we'll have lunch ready. Thank you.